Comprehensive Q&A on the surgical management of gastric cancer. Welcome to today's episode of the Everything Surgery podcast, where we take a deep dive into the surgical management of gastric cancer. We'll be addressing essential questions, covering everything from anatomy and staging to surgical techniques, adjuvant therapies, complications, and current controversies in the field. Pause video when you hear the word answer to attempt answer. Let's get started. Anatomy and pathophysiology question. What are the anatomical regions of the stomach? Answer. The stomach consists of the cardia, fundus, body, antrum, and pylorus. Question. How is the stomach supplied with blood? Answer. It receives blood from the left and right gastric arteries, the gastroepiploic arteries, and the short gastric branches of the splenic artery. Question. Can you describe the lymphatic drainage of the stomach? Answer. Lymphatic drainage involves the perigastric, N1, celiac hepatic splenic, N2 and para-aortic N3/M1 nodes. Question. What is the sentinel lymph node concept in gastric cancer? Answer. It's an investigational approach that aims to identify the primary nodal basin for early-stage tumors, but it isn't yet standard of care. Question. What's the most common histological type of gastric cancer? Answer. Adenocarcinoma accounts for 90% of cases, classified as either intestinal or diffuse. Lauren classification. Question. What is signet ring cell carcinoma? Answer. It's an aggressive, diffuse-type gastric cancer known for its poor prognosis. Question. Could you explain linitis plastica? Answer. Linitis plastica refers to diffuse infiltration of the stomach wall, giving a rigid, leather bottle appearance. Question. What role does Helicobacter pylori play in gastric cancer? Answer. H. pylori is a class I carcinogen that causes chronic gastritis, leading to atrophy, metaplasia, dysplasia, and finally cancer. Question. What is hereditary diffuse gastric cancer? HDGC? Answer. This syndrome involves a CDH1 mutation, conferring a 70% lifetime risk and often leading to prophylactic gastrectomy. Question. What is EBV-associated gastric cancer? Answer. EBV-associated tumors are often MSI high and PD-L1 positive, making them more responsive to immunotherapy. Diagnosis and staging question. What's the gold standard for diagnosing gastric cancer? Answer. Upper endoscopy with biopsy. Question. What's the role of endoscopic ultrasound? Use? Answer. Use is instrumental for T and N staging, with accuracy rates of around 80% for T stage and 70% for N stage. Question. How does the T&M staging system work for gastric cancer? Answer. T1 to T4 reflect depth of invasion, N0 to N3 the number of involved lymph nodes, and M0, M1 denotes the presence of metastasis. Question. What defines early gastric cancer? Answer. Cancer limited to the mucosa or submucosa, T1A or T1B, boasting a 5-year survival rate of over 90% following resection. Question. What is a D2 lymphadenectomy? Answer. D2 dissection involves removal of both perigastric, N1, and celiac, hepatic, and splenic, N2 nodes. Question. What is the purpose of CT and PET-CT for staging? Answer. CT is vital for identifying liver, peritoneal, and nodal metastases, while PET-CT's utility is limited, especially for diffuse or signet ring types. Question. What is peritoneal lavage cytology? Answer. A positive result. CY+. Upstages disease to M1, indicating poor prognosis and contraindicating curative resection. Question. Why is HER2 testing important? Answer. HER2 positivity predicts benefit from trastuzumab therapy in metastatic cases. Question. What about MSI and PD-L1 testing? Answer. MSI high or PD-L1 plus tumors may respond better to immunotherapy. Surgical management question. What is the standard surgery for distal and proximal gastric cancers? Answer. Distal tumors, subtotal gastrectomy, if 2 cm from the gastroesophageal junction. Proximal tumors, total gastrectomy. Question. What does R0 resection mean? Answer. It means achieving microscopically negative margins, which is the goal of curative surgery. Question. Is there a required margin length for resection? Answer. Traditionally, 5 cm was recommended, but now 2-3 cm is sufficient for intestinal-type tumors, provided R0 margins are achieved. Question. What is the difference between D1 and D2 lymphadenectomy? Answer. D1 involves only perigastric nodes. D2 add celiac, hepatic, and splenic nodes. D2 is standard in the East, more selective in the West. Question: what did the classic trial show? Answer: D2 lymphadenectomy improved 5-year overall survival compared to D1. Question: are splenectomy and pancreatectomy always necessary during D2 dissection? Answer: no. Organs are preserved unless directly invaded to reduce complications. Question: what is the role of laparoscopic and robotic gastrectomy? Answer: laparoscopic gastrectomy is non-inferior for early cancer. Robotic surgery may have advantages in complex dissections, albeit with higher costs. Adjuvant and neoadjuvant therapy. Question: when is adjuvant chemotherapy indicated? Answer: for stage 2 and 3 disease. FLOT or ZLOX regimens are common. Question: what is the FLOT regimen? Answer: it's a combination of docetaxel, oxaliplatin, 5-FU, and leucovorin. Question: what were the key findings of the MAGIC trial? Answer: it established a survival benefit for perioperative ECF chemotherapy. Question: is neoadjuvant chemoradiation used? Answer: it's less common for gastric, more so for gastroesophageal junction tumors, as in the CROSS trial. Question: what about HIPEC? Answer: hyperthermic intraperitoneal chemotherapy is controversial, reserved for select cases of limited peritoneal metastases. Question: when is palliative gastrectomy or chemotherapy considered? Answer: for relief of obstruction or bleeding in metastatic disease. Systemic therapy options include FLOT, ZLOX, and immunotherapy for specific tumor profiles. Complications. Question: what are the main surgical complications? Answer: anastomotic leak, 5 to 10%, especially at the esophagojejunostomy, dumping syndrome, afferent loop syndrome, Roux-en-Y stasis, alkaline reflux gastritis, vitamin B12 and iron deficiency, weight loss, pancreatic fistula, and chyle leak. Question: how are nutritional deficiencies managed post-gastrectomy? Answer: lifelong vitamin B12 injections and iron supplementation are often necessary. Special scenarios. Question: how is cancer at the gastroesophageal junction staged and managed? Answer: the Siewert classification guides management. Siewert 1 is distal esophagus, 2 is trucardia, 3 is subcardia. Surgery may require total gastrectomy with distal esophagectomy. Question: what is the approach for hereditary diffuse gastric cancer, HDGC? Answer: prophylactic total gastrectomy is recommended, often between ages 20 and 30. Question: how are lymphoma or GIST of the stomach managed? Answer: mild lymphoma responds to H. pylori eradication, while diffuse large B-cell lymphoma requires chemotherapy. GISTs, 2 cm are treated with imatinib or surgery. Question: what is a Krukenberg tumor? Answer: it's a metastatic ovarian tumor, signifying poor prognosis. Question: what is a Sister Mary Joseph nodule? Answer: an umbilical metastasis, often a marker of peritoneal spread. Question: what is the peritoneal carcinomatosis index, PCI? Answer: a scoring system to quantify the extent of peritoneal metastases. A score above 17 is associated with poor outcomes. Controversies and advances. Question: is D2 lymphadenectomy the global standard? Answer: it is preferred, especially in experienced, high-volume centers, due to improved outcomes. Question: how do Western and Eastern approaches differ? Answer: routine D2 in the East versus selective D2 in the West, based on institutional expertise. Question: are there advances in minimally invasive surgery? Answer: yes. Laparoscopic and robotic approaches are expanding, especially for advanced cancers. Question: what is the future of immunotherapy in gastric cancer? Answer: trials are ongoing for neoadjuvant and metastatic settings, especially in MSI-high and PD-L1+ tumors. Question: what is the role of liquid biopsy? Answer: circulating tumor DNA is being explored for recurrence surveillance. Question: are there novel targeted therapies? Answer: yes. Agents such as pembrolizumab, trastuzumab deruxtecan, and ramucirumab are showing promise. Miscellaneous question: how are tumors classified morphologically? Answer: the Borman classification, 1, polypoid to 4, Linitis plastica, and Lauren classification, intestinal versus diffuse are standard. Question: how is postoperative surveillance conducted? Answer: CT scans every 6-12 months for 5 years and annual endoscopy are standard. Question: What are the most important hereditary risk factors? Answer. Mutations in CDH1, BRCA, and Lynch syndrome are notable. Question. What are the 5-year survival rates by stage? Answer. Stage 1, 70 to 90%. Stage 4, less than 5%. Conclusion. Thank you for joining our comprehensive Q&A podcast on the surgical management of gastric cancer. Stay tuned for our next episode, where we'll continue to explore key topics in surgical oncology. If you have questions or would like to hear more, please leave a comment below.